Hi there. The recording you're about to see is a video of the Scotland ITP support group meeting, which took place on Thursday, the 21st of January 2021. Our expert for this session was Dr. Catherine Baggott from Glasgow Royal Infirmary. And I know lots of you will probably have questions about COVID and the vaccine, etc., if it follows the same path that the meeting last week did. So just like to hand over to Anthony. You had a question?
Yes, Mervyn, thank you. Thanks for that. I thought it would be quite useful to start off the questions with something that isn't COVID related, just for a change, because COVID seems to be dominating everything that all of us talk about and worry about at the minute. So my question was that I've been myself living with ITP for 15 years, and in that time I seem always to be colder than everybody else in my house, everybody else that I ever am in the company of. And it may be anecdotally, I don't know if there's any actual evidence or studies to confirm it, but I've done a number of sort of polls on the ITP Support Association Health Unlocked forum, and I get quite a lot of feedback to suggest that I'm not alone when it comes to being colder than a polar bear in an igloo most of the time. So it seems that it is something that is fairly common, and I just wondered, is it anything to do with ITP? Is there anything in it whatsoever? It could be, of course, that we just don't know because the research hasn't been done. Or is it that I need to just put more layers on?
So it's not something that I'm aware of that's recognised. No. But having said that, I think that we all know that fatigue is now a well-recognised symptom of ITP. And I think if you said that 10, 15 years ago, they'd say, no, how can fatigue be associated with low platelets? So I think you have to keep an open mind. And that's where I think things like the UK ITP registry come in quite helpful to record a lot of these other symptoms to see if they are something that people are experiencing. But no, I mean, the other thing you always have to bear in mind is we know that other autoimmune conditions are associated with ITP. So, you know, having your thyroid check, for example, would be something that's worth doing. I'm sure that's been done them in the past.
Or checking my central heating, probably. Yeah, wow.
Yeah, I think you have to keep an open mind about all these symptoms, because we know that, you know, things are associated with ITP, such as fatigues, that didn't used to be recognised.
I was just astounded that when I did I set the poll on the Health Unlocked site, and I think about 80% said, yeah, we agree with you. I'm always cold. So it's just probably coincidence. But as you say, you could probably, with ITP, never say never, I suppose. And that's fair, I guess. Thank you.
Thank you, Anthony.
I personally think it's horrible to feel cold, and I always put an extra jumper on because I don't really like being cold. And I mean, you look at me now, I've got a t-shirt and a jumper on. So, you know, I haven't got the radiator on in here because I got a bit warm earlier on, but I would just put another jumper on, see how you feel, see if that makes any difference, because if it doesn't, then it probably it could be something. But otherwise, it probably just, you know, that you're feeling cold because you haven't got enough clothes on. Maybe.
It's possible. Absolutely. You can never really say for sure. But I just found it interesting that quite a lot of other people seem to throw it out there as a sort of common issue. But I don't know.
I'm just looking at it.
Yeah, I can also relate to that. I can be in a room where other people naturally just warm and everything else, and I can feel colder, but primarily it's more so my hands and feet that get I feel, I don't know whether it's an ITP thing or not, but I always feel that my legs and the lower my feet always get more fatigued than the rest of me, and I don't know why, but I always I feel that my lower legs always feel more fatigued than anywhere else.
Okay, interesting one. Okay, any other questions, anyone? Someone must have a question about the vaccine.
Yes.
Marlene, go ahead.
Sorry, am I on vision? I can't see myself.
Well, we can't see you, but go ahead, we can hear you.
Yeah, I don't know how to get the camera on. Sorry about that.
It's
Okay, I just wondered if you start out with a lower compromised immune system, i.e., I haven't got a spleen, is there any data on how the compromised system might respond to the vaccination, i.e., would we respond pro rata to the inoculation, the stated rates?
So that is an unknown. So it's possible that people who are immunocompromised in whatever way, whether they be on steroids, whether they be not have a spleen, whether they be on chemotherapy, there is a possibility that they will not be able to mount the same immune response as someone who does have a spleen and is not on steroids and is not on other immunosuppressants. But there is absolute consensus amongst the medical profession that if you are immunocompromised, because you are at increased risk of catching and having bad symptoms from COVID, that you should get the vaccine. Because even if it doesn't offer you 95% protection, if it offers you 70 or if it offers you 50, that is far, far better than having no immunity to it at all. And there's no risk of infection with the vaccine. These are not live vaccines. They are completely safe. They will not give you COVID. So yes, I want all my ITP patients to be vaccinated against COVID. Well, I want everyone to be vaccinated against COVID, but so no, yeah, I can't guarantee that your response will be as good to the vaccine, but I would strongly, strongly recommend it.
Absolutely. It's just that I hadn't heard anything about if there'd been any data on compromised systems, and thank you.
Yeah, it'll hopefully it's something we will know in time. But until, you know, a few million people have been vaccinated and we have the data in from, you know, do people without a spleen get COVID more frequently than people without a spleen once they've been vaccinated, you're just not going to know. But we do know how vaccines work. We know that they have to have functioning B cells and T cells, these lymphocytes that promote the development of antibodies and immune response. You know, if those aren't working properly, then you're not going to be able to mount as good a response. But some response is always better than no response.
Absolutely.
So yeah.
Thank you so much. Thank you. Yeah.
Thank you, Marlene. Who else has got a question? Shami?
Hi, I'm Shamila. I'm in New York City.
All right. Well,
how are you?
How are you?
We're well.
You're a lot happier in New York now then. Yeah.
Yeah, I wish I was in Scotland, honestly. We were scheduled to go last year again for the second time in our lifetime. And we were so disappointed. But we got shut down like everyone else. And here we are. And now we're waiting for vaccines and we got a new president. So, you know, hopefully good things are happening over here.
Happy days at long last. Yeah. Happy days. What's your question, Shami?
What do you anything that we can do before our vaccine to help, or after our vaccine? Any recommendations to, you know, do we take Tylenol before? Do we rest? Do we not? Anything in particular to that effect?
Sure. So there's a really good, I think it's publicly available, but it's very much for healthcare professionals, a green book of vaccination. And they've brought out a brand new chapter that's purely on COVID, with advice about people at bleeding risk and people on anticoagulation. So there's nothing beforehand to particularly do at all. We're certainly recommending that if as a doctor or a nurse, you think that one of your patients is at bleeding risk, and so that would apply to someone with a low platelet count, probably when it's less than 30. I wouldn't be concerned about increased risk of bleeding with anything more than 30, but it does go into a muscle, so there is an increased risk of getting a bruise and possibly getting a very small, you know, collection of blood, a very small hematoma. So we're recommending that anyone who thinks increased bleeding risk, so anyone here who might have a platelet count less than 30, is once you've had the vaccination, just press on it for 2 minutes. Don't rub it, just press it. And that will hopefully limit any bruising. with regard to symptoms afterwards, I mean, certainly because I'm a healthcare worker, I've had my first vaccine, and obviously I know many, many people who've had their first vaccine. The vast majority of us have been completely well, nothing at all. In fact, it's you almost worry, you know, if I definitely had it, you know, because I had a bit of a sore arm, but it was otherwise absolutely fine. So, you know, sometimes you get the flu vaccine and you feel a little bit grotty for 24 hours. That didn't happen for me at all. I think some people have had a bit more soreness in their arm than perhaps I experienced. Some people have felt very, very slightly achy but really, really mild symptoms. So I think the vast majority of people are not experiencing bad reactions. I mean, you may have heard in the news that a couple of people who were known to be very, very allergic did have quite nasty allergic reactions to the vaccine. But that's always known with any vaccine. If you're very, very allergic, and you'll be asked this when you go for your vaccine, if you are very allergic, then there will be a discussion about whether it's the right thing for you or not. But otherwise, compared to some of the vaccines I've had, it was incredibly fine. I didn't experience anything. There's been some anecdotal reports after the second vaccine. People have felt a little bit more unwell in terms of, you know, aches and, you know, just feeling a bit lethargic. But obviously hardly anyone's had a second vaccine yet. So we don't have so much reported. But certainly from personal experience and speaking to many, many colleagues, it's all gone very well with very little symptoms.
And any difference between Pfizer and Moderna or anything else that you guys are having there?
No, so in the UK, sort of for the first 4 weeks, everyone got Pfizer, and then since the sort of the 7th of January, the vast majority have been getting the AstraZeneca. The Moderna, I think we've just got approved for Moderna, but it's I'm not aware of that being rolled out at all yet. Generally, so no, I mean, both vaccines are incredibly effective. You were going to be able to apply for a license as long as you had safety, as long as you had 50% effectiveness, and all of the vaccines are way more than that, which is just amazing. So I wouldn't worry about which one you get. I would have been happy to have either, without question.
Does that answer your question, Shami?
Absolutely, thank you.
Thank you very much. Got another question from Nicole. Nicole, would you like to ask it? Yeah.
Yes, I'm going to read my question.
Yeah.
My question is, are there more people who have been diagnosed with ITP who have received the diagnosis after having got a vaccination? And I wonder what the experts know about that.
Sure. So there is a small link between vaccination and ITP. The strongest evidence is actually with the MMR vaccine. That seems to be the one where there's the strongest alert, but it's still pretty rare. You know, most people who have ITP haven't got it through a vaccine. And I say to all my patients who've got ITP already, if you get a virus or if you get a vaccine, there's always a small risk it might make the ITP worse. There's definitely a possibility, but the risk of that compared to the risk from COVID, there's just no comparison at all. I just wouldn't worry about it at all. You know, I can't guarantee that someone who has had ITP or still has ITP might not have it made worse by the vaccine, but it is very, very unlikely to occur. And if it does, it can be treated. And the other thing to say about vaccines and viral infections, which are two things that can trigger it, particularly in children, is that it's generally always temporary. So it's when you know how ITP has been provoked, it's much, much more likely to get better without any treatment. So even if we are, you know, we're not going to know for a long time yet, but even if we do see that there's a dip in people's platelets counts after they've had the vaccine, the COVID vaccine, for example, then you know, we will want to know about that, but it will still be temporary, almost certainly. It was something I was going to say actually that would be great, is that we are, as doctors in the UK, really interested to know what does happen to people's platelets counts when they have the vaccine. Now, we don't think we can really ask patients to have a platelet count done before and after the vaccine. We don't want people coming up to hospital. But if for any reason you were having a blood test, you know, as part of your treatment, then if you let your doctor know I had the COVID vaccine last week, then at least we can document that. And that sort of thing, you know, can probably be added to the ITP registry in the course of time. But we're not going to know if the COVID vaccine is going to make ITP worse, but it's highly unlikely, highly unlikely. Really, the only one has been the MMR, and even that's a weak risk factor.
Okay, yeah. Yeah.
Thank you, Nicole.
Just
One question after the next one, Nicole. Okay. Anina?
sorry.
Oh, hi. Good evening, everyone. I'm based in London, so thank you for accepting me tonight. I've had ITP for 17 years now. Very, very interesting, very informative being here. Obviously, I'm unsure whether I'm going to have the vaccine as of yet. I keep a very close eye as to how things are developing. I'm really grateful to Nicole's question, because it was kind of one of my worries with well, I'll just quickly show an article a friend sent me. I don't know how true this is. Basically, it said perfectly healthy doctor from Florida. After having the vaccine, he has he's actually developed ITP. And
Yeah, well, I think that's still, and then I think regarding whether it was ITP or not, I spoke to Adrian about this earlier, and I believe that's still examining the results of that, because that first came out about 2 or 3 weeks ago, Catherine.
Yeah. So we were all made aware of this because we knew it would be an understandable question for people. I think there's a few things to think about here. Obviously, you know, was it definitely ITP? Because the problem with this gentleman was that he didn't respond to any treatments. Now, obviously, I know there are some ITP patients out there who don't respond to prednisolone, who don't respond to intravenous immunoglobulins, and he didn't respond to any of these treatments. So we do have to be a little bit cautious. Was it definitely ITP? But let's say it was ITP. Yes, you have to consider, was it the vaccine that could have triggered it? It's possible. But the other thing we've got to think is that at the time that gentleman developed ITP, about 15 million people in the world had had a vaccine. And I appreciate that there could be other people in the world who haven't reported the fact that they developed ITP from the vaccine. But for one case reported in 15 million, to a certain extent, is very reassuring. I mean, we would consider that to be a very negligible risk if you're looking at a risk of 1 in a million or 1 in 5 million, or even as much as 1 in 15 million.
So that's where it shows that it's good to know all sorts sides of the story. It's not to believe, obviously to follow, to check, to have more of an informed choice. Because from personal point of view, I remember that when the swine flu vaccine came out, and there was a big worry back in 2007, I think, or 2006 or 2007, I went for the swine flu vaccine, and I had a really bad reaction. The platelets were dropping. I've had not very pleasant reaction after the swine flu vaccine, which then made me think, why did I rush into the swine vaccine? With hindsight, I could have not taken it, but now I'm isolating, trying to get more information, listening to what everyone has to say, trying not to go into conspiracy theories in any way. As you say, that Florida doctor reacted in a different way, but it's reassuring to see that so far it's not the case that it will trigger a bad reaction or people will have the ITP. Again, if someone offered me the vaccine today, I would still wait and see. This is my stance.
It has to be a personal choice. It has to be a personal choice. You know, the vaccination is voluntary in this country, and I think that's the way it has to be.
Thank you.
Okay, there's another question on here, and it's we've got a few answers on it as well from Linda. Any advice re diet?
Is this with regard to ITP? Is this with regard to ITP?
Yeah.
I don't want to be cynical, but unless you are deficient in vitamins, I mean, this isn't related to ITP, it's just be related to a low platelet count generally. Unless you're deficient in vitamins, there is nothing you can do to prevent ITP. And apart from the medication that I'm able to offer, that we have experience, or the medical establishment's been able to offer, I'm not aware of anything out in the community, for example, that does boost platelet counts. But if anyone has any evidence base for me otherwise, I'm more than happy to look.
Okay. We've got a question from Vanessa. Is Vanessa here?
Yeah, I'm here.
Yeah, Vanessa, would you like to read
Yeah.
your question out, or do you want me to do it? Do you want to do it? Yeah. Go ahead.
Yeah, it was just to say, I'm on Revelade just now, and I had to go on steroids a couple of months ago, and I had really bad headaches. They lasted about 10 days. I've never really had them that bad before, so it was just to see that if anybody else has had that, and is that a known side effect?
I mean, I should probably let the group answer that first, because it is actually what patients have experienced rather than what it says in the side effect list. Has anyone experienced? I mean, I would certainly not be surprised by getting headaches on dexamethasone. Were you taking 40 milligrams once a day for 4 days?
I think it was, yeah. Because I've been on the steroids before, but not with the Revelade. So my doctor thought it might have been with that. But I was actually at the hospital today, and my platelets have went down again, so I have to go on steroids. But I'm a bit more wary about going on them again because of the headaches.
Sure. So it's always hard to know. I mean, and headaches are reported with L-Tromopag and roriplostim as well. I mean, any of you that have looked at the package insert on either of L-Tromopag and roriplostim will see there's loads of side effects, and headaches is one of them. Now, you said you've been on L-Tromopag for a while. Adding in the dexamethasone, steroids will definitely cause headaches as well. Is it the combination of the two? It's difficult to know. But dexamethasone, when you give it as a pulse for 4 days, is very, very intense, and maybe you would be better, if you have to go on steroids again, to use prednisolone, because that is far less intense on a day-to-day basis than dexamethasone. So that's I mean, none of this is proven. We can't sort of say, yes, your headache was definitely due to this, but I think it's suspicious if you get a pulse of dexamethasone and then for the next 10 days you've got a really bad headache. You have to think, well, what is it? Was it that? And if I need to use steroids again, perhaps I should use a different dose of steroids. And I would think it's a low dose of steroids, such as prednisolone, like a dose of 40 or 50 milligrams a day, rather than these big boosts of 40 milligrams of dexamethasone a day, which can be highly effective. And patients often like it because you give it and it's done for 4 days, and you feel a bit ropey for those 4 days, but then it's done. But it is a bit of a short shock. And so if you were a patient sitting in front of me, which I suppose you are, but you know what I mean, in clinic, I would say, okay, let's go to prednisolone next time and not give you such a wham of steroids in one go.
Yeah, I had been on the other steroids right at the start when I was diagnosed. So I have been on them before, but yeah, I was on them for about 6 months, I think it was.
And that has its own side effects, being on steroids for 6 months as well. So that's why some people do like to have that big sort of 4-day dose of dexamethasone. But no, that's what I recommend. If I was, if you came to me with that question, that's what I'd recommend.
Right. Okay, thanks.
Okay, thank you. Nicole, you had a second question. You're on mute, dear.
Yes, I have a second question. Thank you. I have read and heard that when some people who have ITP get a vaccination, that their platelet count drops. It can be a vaccination for the flu or for traveling abroad. But my question is, what do the experts know about that?
Yeah, so I don't think we know definitely why it happens, but the theory as to why your platelet count might drop when you get a vaccine is that we know that ITP is due to the immune system being dysregulated. So we don't know why ITP suddenly appears, but there is some reason that your body suddenly, your immune system suddenly sees a platelet as foreign and is trying to break it down more quickly. And to me, it makes logical sense that if you see a virus, you know, you get a cold or you get the flu, then your immune system has to respond, and sometimes it will respond incorrectly and break down your platelets at the same time. And some people, where that happens, the immune system recovers and the platelets get better. And in some people, when that happens, it doesn't. Although when you know it's definitely been triggered by a virus or a vaccine, it generally is much more of a temporary thing. So I think the reason that a vaccine may be related to the platelet count getting worse or ITP appearing in the first place is going to be you are appropriately having an immune reaction to that vaccine. That's what you're supposed to be doing. And very occasionally the immune system will work too well or not quite right and see the platelets as foreign as well. So, and if you've already got ITP, it's the same thing. You know, we know that if you get a cold or a flu with ITP, some people will see a drop in their platelet count because their immune system is suddenly activated. So I can't guarantee if you've got ITP that your platelet count won't fall. If it does, I would hope it'd be temporary given what we know already. I suspect, just as with the vast majority of vaccines, hardly anyone's ITP will get worse. That would be my opinion, my professional opinion. I don't think I've got great evidence base, but certainly of all the vaccines we've had over the last 50, 60 years, you know, we do have information that ITP is not a common phenomenon after you give it. As I say, MMR was probably the strongest. And although I don't have the figures to hand, I doubt that was probably more than 1 in 10,000 or 1 in 100,000. It wasn't that you suddenly saw a massive peak in ITP in children when they started getting it 18 months. But there would have been a bit of a signal, and that's why that has come out. Okay. And it makes sense. It makes sense logically, physiologically. But as I don't think I can stress strongly enough, given everything we've all seen, and perhaps me working in a hospital have seen, you just don't want COVID.
No.
You know, and yes, there are risks to the vaccine. Of course, nothing is 100% safe, but you really, really don't want COVID.
Okay. Thank you. Thank you.
Thank you, Nicole. Ali, you got your hand up. You're on mute. That's it. Go ahead.
Yeah, I'm not now. I should be used to it. I'm doing it all the time at work.
Are you sitting somewhere very cold?
Well, I'm feeling, going back to the earlier question, I was feeling cold. I'm sitting with a jacket on in the house. The heating's turned up.
Oh,
I'm starting to warm up now, though. No, you answered my question. I just got word today from management to attend a clinic to receive my vaccine. I work in the community as a health nurse. I did wonder, was it worth me? I could actually try to get in touch with my haematologist today, but which never got very far, just to get a wee bit of advice. So that's why I've joined the group tonight. My counts.
You're breaking up a little bit.
Yeah, your signal keeps dropping out, Ali. So
if you
it must be because I'm in the Highlands. I'm sorry.
Ali, just try turning your video
I don't know
off.
if that'll work.
And just keep the audio on. Yeah. No, you've turned your audio off now.
There we go.
Brilliant.
Right. Okay.
Is that better?
Yes.
It sounds better. Yeah.
Right. I'll catch the chase. My count sits about 25 at the moment. Good days is 40, 60. But you did answer my question about the reassurance of getting COVID. You know, COVID vaccine is outweighing the potential risk. But you did mention a low count there just now in one of the other questions. Is it worth me getting a test done first?
Right, so we're certainly not recommending that you get additional blood tests done, because we want you to avoid health areas as much as you can. So if you need to have a test because that's part of your care for your ITP, then you should, but you shouldn't have any additional. But just to sort of recap, if your platelet count is normally about 25, then with it being under 30, there might be a slight increased risk of bruising, not much, but a little bit.
Right. Okay.
So we recommend that as soon as the vaccine's done, you just press on the area for a few minutes, just firmly, don't rub, because that can sometimes make it worse. You just press on the area for a few minutes, and that should minimize any bruising or any collection of blood or hematoma under the skin. We're particularly recommending that with the COVID vaccine, because the COVID vaccine is given into a muscle rather than just under the skin, and that can lead to a bit more bleeding potential. But the needles are tiny. I mean, they're really, really small. So we're not overly worried as ITP doctors, but we think that, and certainly I was talking about this green book, this vaccine book for the UK that has a new chapter on COVID. The recommendation is certainly if you're on an anticoagulant like warfarin, or you've got a low platelet count for whatever reason, then you should press on the site where you've had the vaccine for a few minutes.
Okay, was that okay, Ellie?
Yeah, that's great. Thank you very much.
Thank you very much. Who's got the next question? It must be someone. Sue?
Can Dr. Baggett tell us how many people in Scotland have ITP?
Oh, Lord.
Good question.
So right now, because obviously some people have it for a long time and some people don't have it for very long. So it's about 1 in 100,000. So that means that in Scotland, that can't be right though. That can't. I mean, it is about 1 in 100,000, but that would only be 60 people in Scotland, so that absolutely cannot be right. But no, that's new diagnoses though. That's true. That's new diagnoses per year. So the incidence per year is 1 per 100,000. So 60 new cases of ITP are diagnosed every year in Scotland, roughly. But obviously people have it for longer than that. I mean, I know on my books in Glasgow Royal, at the moment, well, it's difficult though. I know that I've got about 120 people who've gone onto the UK ITP registry since I've had it on my site since about 2012, but not everyone goes on the registry. And obviously those 120 people aren't all under my care all the time, because some of them get better. So I think it would take some complicated maths actually. If you've got 60 new cases per year in Scotland roughly, and what's the average duration of ITP, you can probably work it out. But I'm afraid I don't know. I probably could find out. I could maybe come to the next meeting and see if I can tell you. But obviously it's not like a notifiable disease. So, you know, you don't have to say that you've got ITP. What I can say, I suppose, is that the UK ITP registry has about 4,500 people on it now. And that's been running, well, in its new form for about 10 years or so. So that gives you sort of some idea, but obviously some of those people still have it and some of them don't.
Yeah, thank you. It wasn't meant as a trick question. It's something I've always been curious about, because I was diagnosed in 2015, and for a period I was going, well, weekly, then monthly, to the Edinburgh Royal Infirmary. And every time I was there, I was sitting amongst people with diabetes and other things. And I've often wondered how many people, the consultants I was seeing, had ITP, how many people they were seeing with ITP and how much experience they had, which is not to say I wasn't respectful of their professional expertise. But if we're only seeing maybe 1 or 2 people a month, you know, was I being given the right treatment was basically what it came down to.
And I think that ITP is considered a rare disorder. It meets that classification. It's not common. So and you probably, I don't know what patients here would think, but when you're first diagnosed with ITP, you've probably never heard of it before.
No.
Because it's not like diabetes or a heart attack or a stroke when everyone's heard of them. ITP is like, what on earth is that? And that's probably true of some doctors as well. So if you're a surgeon or an obstetrician, you will know nothing about ITP, whereas you probably do know a little bit about heart attacks and strokes. So it's not a common condition. And because of that, you sort of mentioned, you know, it's possible that some hematologists may not have loads of patients with ITP. And that's why partly where the UK ITP forum came from for doctors, if you like, why we set up the centres, to try and have a group of doctors who not only had a special interest, but might have a few more patients. So they just get to see the sort of more difficult cases, the more weird and wonderful, and perhaps have the opportunity to be able to look at the literature a little bit more than hematologists who are looking after leukemia and that sort of thing. And that's why I suppose in this day and age we're lucky, because we can now communicate so easily that you can get that experience around to other doctors who perhaps don't see it quite so much. But now I meet a lot of people, obviously, a lot of people with new diagnosed ITP, and they're like, what is this? Because I never heard of it. And that's why the patient group's so important, because you can feel so isolated.
Yes.
I think.
Thank you.
That point has been raised loads and loads of times over the years, as I'm sure, you know, Rhonda would confirm. You know, patients saying, you know, they went to their GP and this was the first case of ITP they had ever seen in their career. You know,
Yeah.
it happens a lot. So, yeah.
Yeah. Just to come in on that there, Mervyn, since you mentioned my name, I think that this is something that is very, very unrealised in healthcare. And I think that is the shock of being diagnosed with a disease that you've never heard of, that is probably in an adult going to be long term, and that you're going to have to adjust to living with possibly for the rest of your life. And I think that probably all of you can relate to that. And this is I think it's, you know, we need to have a sort of an area which is called the psychological impact of your diagnosis. And I think that is like for absolutely everybody. I mean, if you go to a doctor's surgery or a specialist surgery and they say you've got cancer, you know, you're going to be pretty shocked. And I think that the psychological aspects are possibly not dealt with enough. I don't know what you think about that, Dr. there. What do you think?
Yeah, and I think, you know, I put my hand up as a doctor. You know, I haven't experienced ITP. I haven't had cancer. It's, you know, as a doctor, there's only so much empathy you can have to be able to appreciate what it means to, you know, I've got ... whatever it might be. The moment you're told that diagnosis is a very lonely time, particularly when it's something you've never heard of. I think there's a little bit more understanding of that these days. It's nowhere near good enough, but I think there's a little bit more appreciation that it is a shock. And I suppose being a sort of non-malignant hematologist, so I don't deal with leukemia and lymphoma. And sometimes I think I felt, you know, people sort of think, well, if you're told you've got leukemia or lymphoma, well, that's really bad, that's cancer, and therefore there's lots of specialist nurses and perhaps more support groups. But having a non-malignant diagnosis, whether that be ITP or a similar condition where you break down your red cells, they can have really life-limiting consequences. And I think, you know, I can say all these things, but I haven't experienced them myself. But I think there's a little bit more of an understanding that just because it's not cancer doesn't mean that it's not very concerning and something that you've got to live with, and friends and relatives haven't heard of it, and therefore they don't quite understand why you might be worried about bleeding or bruising, because they're like, well, there doesn't seem to be anything wrong with you. So yeah, I think there's lots and lots of psychological elements, and I wish we had more support for patients psychologically. I think though groups like this, though, I would like to think make a huge difference, because you're now surrounded by people who haven't had the same experiences of you, but have had similar experiences. So no, but I completely agree with what you're saying. Absolutely.
Yeah, well, of course, that's why the ITP Supports Association was set up by Shirley, because her son was diagnosed with it and she couldn't find out anything about it. And then, of course, you know, this is what Anthony does on his social media, you know, like every day. I mean, I'm not a social media person, but, you know, people do find that very helpful, very supportive and very psychologically supportive. And I think, you know, just going back to one of the previous conversations, I think that everybody has to be prepared to assess their own risk as well. You know, your own risk of doing things now that we're in a pandemic. You know, do you do this or that or the other, and is it too dangerous, and what is the risk, and should I do it or not? So I think that's one issue. And then, of course, the other issue is being able to evaluate the treatments that are being given to you and being able to have a dialogue with your clinicians about this treatment, finding out as much as you possibly can, you know, before you take the treatment. And then, you know, also monitoring it with the supervision of your doctor. And I put in the chat there about the diet. You know, there's nothing, as you said, about, you know, any diets. And there are all sorts of things on social media that will try and get you to spend a lot of money on supplements and things, and mostly they're excreted, or, you know, there's no value in them at all. But do you think you could talk a little bit about, is it Catherine? Sorry, Catherine? Yeah, Catherine. Do you think you could talk a little bit about vitamin D? Because people in this country, and I'm sorry to say, especially people in Scotland, lack vitamin D, don't they? Because of the not being in the sunshine.
Yes, yeah, no, absolutely. So it's a recommendation. I'm trying to call it Department of Health, I can't remember exactly, but sort of high up governmental recommendation from about 2 years ago that pretty much everyone in the UK should be taking vitamin D supplements during the winter when there's less sun. And all this is about is preventing osteoporosis, preventing weakened bones. It doesn't prevent cancer or make your blood vessels more healthy or anything like that. There's lots of rumours about that, but it absolutely does help bone health. And living north of the border now, I take vitamin D every morning because I think you don't see much sun in Scotland, and when you do, it's a bit weak. So I would recommend that everyone takes vitamin D definitely in the winter, and really just get in the routine and take 1 dose every morning. But I'm afraid it doesn't have any more health benefits than just making sure that when you're 70 and 80, you don't fall over and break your hip.
Yeah, but what about calcium and magnesium as well? Because for the bones, the calcium is very good if you're not having a high diet in dairy products. And also the magnesium actually, I think, helps for the calcium to actually be taken up in the bones. Is that not correct?
So so the vitamin D is the most important thing about getting calcium into your bones. So if you're having a normal diet, you don't need to worry about a lack of calcium from your diet, but you won't be able to absorb enough if you don't have enough vitamin D. So only people who've got osteoporosis already need to take vitamin D and calcium. If you take the vitamin D, that will help you absorb the calcium. Magnesium, I'm afraid I'd have to put my hand up and say I don't actually know enough about magnesium to be able to say whether that helps your bones or not. I'm not certain. Out of my area of expertise.
On two extra things that came out of last week's meeting on the vitamin D were that us folk down here in England who are immune suppressed, in other words now shielding or clinically vulnerable, have been offered vitamin D by the government free of charge, but you have to opt in to take it. So if anyone is watching this from England or Wales, you can opt in. You'll be, I think I got directly emailed from somewhere, probably Matt Hancock, my favourite pen pal at the moment. I had to opt in for it, so that was something I've opted in for, and I will be amazed to see what happens. I already take a vitamin D supplement anyway, so it would be no different to me, but it's useful, I think. And on vitamin D, just one extra thing, people may see that there were 3 reports conducted in November last year looking at vitamin D and would it have any impact for those people who contracted COVID, would it help the immune response, etc., etc. There were 3 reports, but they were fairly inconclusive, and I don't think it has any real proven benefit for COVID diagnosed people. So people may see those 3 reports and wonder, oh, here we go, let's all take lots of vitamin D and we won't get COVID, but or if we do get it, we'll get a better response. So just be wary that it's not a cure-all. It's a very useful thing to have, but it's certainly not a cure-all.
I think it's quite interesting, actually. It's something perhaps I hadn't appreciated, that if you are shielding, or have been shielding and now shielding again, and you're not getting out at all and you're not moving as much, vitamin D actually becomes even more important. You're not getting the sunlight and your bones aren't getting the same stimulation with the normal sort of wear and tear of weight bearing. So vitamin D is probably even more important. And I confess it's not something I thought of before, and I can't believe the English government are giving away free vitamin D, blimey.
Absolutely.
They actually in Scotland, they asked back in October, actually, because my mum's in the shielding list, and we got a text back in October for Scotland. So if you're on that text, so she got hers back in December, actually free from Scotland. So we've already, already had that. Yeah.
Well, as Professor Newland said at last week's meeting, you can actually buy it for pennies down at Boots.
You can buy pennies at Boots.
Yeah.
It's true.
Yeah.
I think you can get 100 tablets in Boots or Superdrug or Holland and Barrett, those sort of places. 100 tablets will be sort of £4, £5.
Yeah, it's pretty cheap.
So you might as well, if you get down and get some, yeah.
Yeah, well, my pharmacist actually recommended the, it's more expensive, obviously, it always is, isn't it? The liquid. And I take 1 drop of that in water in the morning with my breakfast. And that is it. It absorbs much more. It's biotech or something one. It's in a little box like that. And it's just a squeezy thing. There's a dropper. And you want to research it, because some vitamin D isn't as good as that. There are different kinds of vitamin D. And also, interestingly enough, in Europe, the daily dose of vitamin D, the recommended daily dose, is double what it is in England. And so you really want to research it. You want to talk to your doctor or your pharmacist or somebody who actually knows, and find out what is the best, because some of it is not absorbed as well as other bits, and other types. So it is really worth looking into it. It is, I've looked into it before, and it is really quite complex.
Yeah, there is a recommended dose on the government website.
Yeah,
I can't remember it off the top of my head. It's either 25 micrograms or 15 micrograms or 10 micrograms. It's not loads, but there is a recommended dose you want to look up. It's public knowledge.
Okay, thank you. That was interesting.
Ali's written, is there enough vitamin D in a multivitamin supplement? I'd have a look on the packet, and it'll say what the recommended daily, what's it called? I think it's RDI, recommended daily intake, and it will say 100% or 150% or 70%. So as long as your multivitamin says vitamin D, and then it should have the recommended daily intake as a percentage, as long as it's 100%, you're fine.
That's great. That's good. Okay, we're now coming into the last few minutes. Who's got the next question? There must be someone.
Hello, it's
Liz,
Marley.
sorry, Linda. You're muted, Linda. Linda, you're muted. That's it. Go ahead.
Is that me now? Can you hear me now?
Yep.
Good stuff. Hi, everyone. I'm Linda, and I'm from Elderslie in Renfrewshire. I was diagnosed 15 years ago as well. I'd like to hear about the ITP registry because I've never heard of it before. And I don't know what it's for or why it's there, or if it would be any benefit to me as a patient.
Sure. Okay, that's great. So the UK ITP registry is ITP is such a different disease for every person, and so what the ITP registry is trying to do is get as much information on treatment, symptoms, platelet counts, responses to treatments, as much as we can on every patient with ITP in the country. All of us, many sites in the UK, many hospital sites in the UK are signed up, and there's a patient information leaflet. It requires an additional sample of blood, and what the blood is for is it gets banked with the UK ITP registry that's based in the Royal London, and they will have all those blood samples which researchers can then apply for to investigate and research ITP. What's your nearest hospital?
I'm at the RAH in Paisley.
Okay. So I know the haematologist there.
Okay.
I will see whether we can work something out to get you a patient information leaflet. Mervyn, how I'd obviously need to know, I'd need to know Linda's details. I'm not quite certain how
I should have them. I'll send you her email address.
Is that okay, Linda?
Yeah,
that
that's
okay,
absolutely fine. Yeah. I actually don't attend the hospital because my platelet count remains stable on medication. I take methotrexate because I have lupus as well as ITP.
Right. Because you're part of my health board, I can probably send you the consent form in the post.
Okay.
Information leaflet. So what I can do, if you are in agreement for Mervyn to give me your email address, I will email you, and then you can give me your address, and we can send things to you.
Right, that's brilliant. Thanks very much. Yeah, thank you.
Great stuff. Thank you, Linda. Right, any other questions? No, I think we'll wrap up then. It's been very useful. Give me a few days and I will publish the recording of this meeting on our YouTube page. But thank you everyone for taking part from Scotland, England, New York, Holland as well. So yeah, thank you everyone.
Well,
take care.
Thank you to you as well. I actually really enjoy doing these. It's nice to sort of meet patients in their own environment. And I don't know, it's nice. It's nice.
We'll have to reschedule another one sometime soon. Yeah.
Yeah, thank you, Catherine, for all your input. Thank you, Mervyn.
Been useful. Thank you.
Yeah, thanks everybody. Thank you.
Take care, everyone.
Nice to see you all again.
Thank you. Bye.
Bye. Bye.
Bye.